take you in so they can do like the CT scan and the echo and see.
Director Garza, who I believe is remotely connected, but I'll circle back on that. Director Harrington?
Present.
Director Curry?
Present.
Director Sorrell is absent. Director Webster Cross?
Present.
And Chair Bott.
Present.
You have a quorum.
Thank you. Good morning.
And I am
everyone.
present. Sorry about that, Madam Secretary.
Thank you very much.
Thank you. Thanks for all those joining remotely. I'd like to entertain a motion to allow Directors Garza and Webster Cross remotely participate in the meeting.
So moved.
Second. Is there a second?
Second.
Any further discussion? Hearing none, all in favor say aye.
Aye. Aye.
All opposed? Ayes have it, the motion carries. The next regular meeting of the Quality Patient Safety Committee is scheduled for Friday, June 7th at 11:30 a.m. Is there anyone registered to provide in-person or virtual oral testimony and submit a written testimony to be included in the record?
We did not receive any registrations nor written testimony.
Thank you. We'll move to the action items. I'd like to have Dr. Claudia Fagan present appointments, reappointments of Sturgeon Hospital Department Division chairs, please. Thank you.
Making sure I have the right folks. I don't. That's fine. Okay, good morning, directors. It really gives me great pleasure to present for appointment Dr. Mallory Williams, who comes to Cook County from Howard University, but has a long and distinguished career. Has a master's of public health as well as his being a doctor. He is a white belt in Six Sigma and has done extensive training in trauma, and he will join us as the new chair of the Trauma and Burn Department. Dr. Williams is nationally known for his work, and in addition to his work as a physician, he is a colonel in the Army Reserve.
Great. Congratulations. I know Dr. Williams, Mallory Williams, is personally, so it's great to have him in Chicago. I'd like to entertain a motion to approve item 3A, the proposed Sturgeon Hospital Department chair initial appointment.
So moved. Second.
All in favor, say aye.
Aye. Aye.
All opposed? Ayes have it, motion carries. Thank you, Dr. Fagan. Go to now the EMS MEC reports action items. So have Sturgeon and Providence Hospital MedStep action items presented for approval, and then Sturgeon and Providence Hospital Quality Committee summaries presented for information. I'd ask Dr. Akintoran, President of Sturgeon Hospital Executive Medical Staff, present any reports. Is he not here? No. Dr. Allegretti is here. There you go. Present report. Any reports? Present medical staff action items for the committee's consideration.
Hi, good morning, everybody.
Good morning.
Good morning. Specific to report, but just everybody received the summary of the Providence Hospital QPI Improvement Committee, as well as medical staff appointments and reappointments. If there's any questions, I'm happy to answer. Thank you.
Any questions? Great. I'd like to entertain a motion to approve item 3B, Sturgeon Hospital and Providence Hospital medical staff reappointments. Appointments, changes.
Second.
Any discussion? No. Hearing none, then all in favor say aye.
Aye.
All opposed? Ayes have it, motion carries. Thank you, Dr. Allegretti. Go to our minutes from April 19th. These minutes were approved at the April board meeting, so being presented for the committee's review and discussion if necessary. Any corrections need to be made to the minutes, directors? I'd like to entertain a motion to accept item 3C, the minutes of the QPS Committee Meeting of April 19th.
So moved. Second.
Motion been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
Aye. Aye.
All
Aye.
opposed? Ayes have it. Motion carries. Excellent. Thank you. We'll go to our operational excellence informational items. No actions needed for these items. I'll ask Rajay Thomas, our Chief Quality Officer, for an OPEX dashboard. Good morning.
Good morning, everyone. So we'll get started with the Sturgeon OPEX Steering Committee report. As you can see here, the monthly percentile box exceeded the target in March and has been trending upward since the beginning of the year. Again, under patient experience work group, survey response rate has been trending below the target. However, we have the work group executive sponsor and the team from all three areas here today to present you all on the tactics as well as the timeline shortly. Moving down under the clinical outcomes dashboard, both FIR and monthly volume for CLAPSIs have been trending positively this quarter. For Cody, SIR is slightly above our target rate. However, if you look at the monthly occurrence data, it's way below, so far. It's trending nicely. We have only 3 occurrences so far. So the team is, as they presented last month, they're doing an exceptional job in ensuring compliance with our Class C as well as Cody bundle for prevention. No VDs reported for the first 2 months of this year. Our target is less than 7 incidents so far, so the team is very optimistic that we will be able to meet our goal for this year. Under the readmissions, the has been pretty positive so far about the target for the rolling 12-month data, and also the readmissions data is performing above our stretch goal for the monthly volume data. For our IHA rolling 12-month all cause or payer readmissions, including other hospital data, we are performing above the baseline for the past several months, and we are very hopeful that soon we will be able to, meet our goal and the stretch goal. For the throughput data, the team will be here to present to the team, to the board, some new tactics and timelines they are introducing based on the data behavior we are seeing. As you can see, we are in the red for the past, couple months. So the team has recently been studying that data, and they have a new approach to our admission throughput data. So throughput tactics. So they will be here next month to present you all on their new tactics. Yes.
What does the color coding represent?
Oh, I am very sorry. I should have introduced you to the legend. Green means we are above our baseline. Dark green means we are at the target. Purple means we are close to the stretch, above the stretch goal.
Can you talk about what, the activities to address any service response rate, trends?
Absolutely. I know Lee is here as well as the diet leaders from, I would be happy to address that, but they are planning to do a thorough discussion around the topic.
Okay.
Right.
Other questions? No? Good, looks like good news to support and celebrate, so I appreciate the work on this. This, on the all-cause readmissions, we'll hear about that as well. All right, so we'll have...
There's some new tactics, as I mentioned, to address the throughput data, which, might be concerning to the board right now, but the team will be here next month to highlight the new approach to admission. All right, moving on to the Provident OpEx work group.
Are you able to say what some of the causes for throughput?
Absolutely. So instead of using the geolocalization model that we've been trialing and trying for the past couple of years, the team, after realizing that that model has added additional time to our throughput data, we are starting July 1st. We will be going back to a model that we tried in the past that seemed to have worked for CCH, which is Q4 admission model. So the services would be taking turns, to admit every 4 days. So they're still fleshing out the details right now. So that's why I don't have a ton of information around how that would look like. But the team, when they present, would have all that detailed information. If you would like additional information, I can pull in experts from the team, the room right now.
Thank you. Should we move on to, do you have questions? No questions. We'll move to patient experience for Stroger. Or do you have other things you want to go through?
Providence and ACHN, unless the board would like to move on to. Okay, so moving on to the Providence dashboard. Really want to highlight and point out the purple areas that we see on that dashboard for multiple areas. And we have the Provident team here today. So I want to call out for the percent top off for communication with nursing domain. They've been doing exceptionally well. For the monthly data, as you can see, they are above the target, stretch target goal. Even for rolling 12 months, it's starting to, starting to be well above the baseline. So we really want to congratulate the Provident team for their exceptional work. Rolling 12 months survey response rate, again, it's above the target rate. Again, the team will be presenting on some of the reasons behind why we are seeing a monthly drop in the monthly volume of return surveys and what tactics are being deployed. Moving down for the clinical outcomes data metrics for sepsis bundle. One of the challenges, as we have shared with the board in the past, the low volume of sepsis cases that we manage at Providence has been a challenge. However, we are pretty happy with the way the data is looking right now. The team also recently introduced reflex lactate as well as continuous monitoring of the rule to see if the rule is really capturing the correct cases. So that should start to show some improvement pretty shortly. All right, moving down to throughput. Hand hygiene data. It's trending very well. As we shared with the board in the past, we had introduced a new way, more effective and robust way of monitoring that hand hygiene observance, the practice we had at Providence, and it's starting to show results. As you can see here, we see some dark greens and purples there. So congratulations again to the Providence team. For the throughput data, the left without being seen data is trending very nicely for the past several months since we introduced this new tactic or set of tactics in February, middle of February. That number has been steadily going down, and the most recent data from March shows that they are well above the stretch target of 4.0. They were at 3.7. So congratulations again to our Provident team here. Tab, we will move on to the ACHN.
Excuse me 1 second.
Yeah.
Just sitting in on this meeting. Acronym LWBS, I want to make sure that
Left without being seen. Director, I'm very sorry. So these are the patients we see in the ED, but are leaving without being seen. So oftentimes it's an indicator of how efficient your ER with their processes to pull the patients in and make sure they have timely evaluation. So the Provident team is actually replicating the process we deployed at Stroger last year that seemed to be working very well and very efficiently for Stroger. So we are scaling the improvement work from Stroger to Provident. So they have very specific tactics like, they have physicians, a physician and nurse who pull the patient. Like, as soon as the patient registers, they are proactively reaching out, doing an initial assessment of the patient to ensure that critically, ill patients receive the care, quicker than, the rest of the patients. But the process of seeing them as closely as they get registered is the main tactic, the overarching goal behind, all that work.
thank you for that background. Appreciate it.
Thank you. All right, moving on to ACHN, our group data here. While rolling 12-month and monthly data for nursing communication have been trending above our baseline for the past several months now. The same goes for the provided explanation of problems and conditions data as well. Courtesy of registration staff, as this is a metric we introduced recently, and that also has been trending well. Again, the team is here to present on their tactics, the effectiveness, and the timelines. They should be presenting to the board pretty shortly. Moving down to the next group of metrics here for HEDIS, the measures have been really trending above the baseline. And as the group presented to the board last month, there are very specific, measures they are taking to ensure that both these goals stay on target and above, meet our goals, for both target and stretch target goals. That's all I have. Any questions?
It's good, to see the progress of Providence. Those numbers, that's nice work. And, on the, registration, it looks like there could be some more work to do with ambulatory.
Absolutely. That's a new metric that was actually one of the audacious big goals that the team introduced just a few months ago. I really want to thank the team for identifying something that usually most organizations do not even, track. So yes, definitely we understand that, that is, that's an area for focus. However, if you look at the numbers, it's pretty close to, our target, even though it looks in the red, it's very close to our target. So we strongly believe that the tactics are working, and we should be able to see the color change from red to green shortly.
Great. And this is where we're collecting demographic data as well.
Yes.
Yeah. Okay. Any other questions? None here. All right. Thank you, Raji.
Thank you.
Before we go to the update from the OPEX work groups, Dr. Akintoran's here, so we'll have Dr. Akintoran present the executive medical staff appointment. Good morning. Good morning.
Director Sarah Curry. I'm presenting to you the report of the Credentials Committee as approved by the EMS Committee for John Stroger regarding the medical staff action items, medical staff appointments, reappointments, and other changes. And if there's any questions, I will be glad to answer.
No questions.
Thank you, sir. Okay, then I will just present this summary of the summary report of the HQPS minutes for the month of March. This was presented to the Medical Staff Executive Committee for John Stroger Hospital. So the regarding hand hygiene, we have a current compliance of 74, where we have 74%, 74.8% in January, 78% in February, and 79.3% in March, with a goal of 8% compliance. Interventions being used to improve compliance of this very important thing that we have to do all the time, that we must do, includes CDC signage about hand washing, to put them in conspicuous places in the unit, retraining of ancillary staff on proper techniques, just-in-time coaching and hand hygiene champions positions in the unit, and also to do screensaver reminders. Regarding our stroke program, for the last 12 months, we've had 380 strokes, total of 19 TIAs. We had 92 compliance with the CSK one with our procedures, and for the VT prophylaxis, we had 97% compliance. Really strong numbers there. OPEX readmissions. Again, this is from March. You have more recent data. Heart failure, 30-day unplanned readmission for patients month-over-month was 12.9%, which is good. Year-over-year comes out to 23%. Oncology patients with palliative care order are now being tracked. Baseline is 15.5%, and the goal is 21.3%, with a straight goal of 29%. Other hospitals like us are usually at 21%, so our goals are appropriate, and we are approaching that. Yes, sir.
You say the numbers are good compared to what? I mean, what's typical?
For unplanned readmission,
right,
for the heart failure.
Is there an average number or?
I believe, I'm sorry again, Dr. Figan, I believe, our stretch goal is 14%, help me, she's helping me, thank you.
If we know what are the causes, or if there's a leading cause for the implant.
So this is a project that we've been working on as an organization, and we're actually comparing ourselves to previous numbers. And we were having we targeted patients with heart failure. We've now expanded it to look at some other diagnoses, but we were noticing that a lot of the patients who we had admitted to the hospital with heart failure, which is the number one diagnosis for patients over the age of 65 who get admitted to the hospital, Medicare recipients. And we noticed that if we were able to, one, see the patient sooner after discharge to make sure that they had all of their medications, so making sure that they got their prescriptions and understood why they were taking their medications, as well as seeing them back as an outpatient and kind of reaffirm what we're wanting them to do at home to stay under control. So when we were seeing these larger numbers in terms of patients now who were being readmitted, we were seeing the majority of readmissions in less than 30 days, which is a Medicare standard, were with this diagnosis, right? So, I mean, it's hard to get those numbers for other organizations, right? They don't usually publish how many of their patients get readmitted. So just by reducing the numbers from, 20, 25% down to 14% is a significant improvement for us.
Thank you.
And on the oncology patients with palliative care order, who gets an order versus who doesn't? If that number is where it is it everyone who's an oncology patient should get a palliative care order, or there's some other parameters?
No, it's not every patient, but I have to say, there's been a huge shift in the organization. That previously there was a real reticence on the part of our team here, outside of what you would consider normal standards in terms of patients being referred to palliative care. And there wasn't much collaboration between the oncologists and the palliative care docs. And so it's been a culture shift that's occurred over the last 20 years in terms of helping people understand that talking about palliative care is not giving up per se, but helping patients understand that we don't have a cure for all cancers, and giving patients the opportunity to think more about what may be a life-limiting event for them. So there's been a shift in that it was only patients were referred only like within the last 2 weeks of life to begin to think about this on a 6-month or 1 year life expectancy and referring those patients. So it's just having those conversations with patients and making those suggestions that they might want to have a conversation. So the primary care docs have gotten involved, the oncologists have gotten involved, and there's certainly more collaboration between palliative care.
So it's mostly hospice-oriented, not management of serious illness.
I wouldn't say that's true at all. Like palliative care does help in terms of pain management and helps patients see what opportunities, how they can live with the illness that they have.
Do we have hospice trained physicians, or they're palliative?
We do have hospice trained physicians, and our palliative care doctors have actually made home visits for patients as well over the years. So we have a very robust service for palliative care that's won some national awards for their work, and they offer the broad expanse of palliative care. We use palliative care now not just for oncology patients, we use it for patients with liver failure, we use it for patients with maybe life-limiting heart failure. So it's a very robust program, but we just had not had as much success in being timely in the referral of patients to palliative care with oncologic diagnoses.
Thank you. Thank you, Dr. Figan. Thank you, Dr. Bass. Again, I'm sorry I was head up in the operating room. I was a bit late. Thank you.
Thank you. We'll resume our OpEx work group reports with patient insurance Stroger, Lee Dang, Jackie Witt, and Dr. Silva.
Good morning, Chair Bott, Director Harrington and Director Curry. My name is Lynn Dang, and I'm the Chief Experience Officer, and I will go over the Stroger work group report out. Excuse me. So, okay. So with this new format, we're sharing our A3 for Stroger Patient Experience Work Group. Data shows that the top 3 key drivers for us to improve our likelihood to recommend are staff work well together as a team, nurses communication, and nurses treat the patient with courtesy and respect, which rolls all up under the nursing communication. Thus, we're focusing on 3 goals. 1, communication with nurses domain. 2, the increased HCAP survey response rate. And 3 is to implement the OAS CAP survey, which CMS required in January 2024. And on the right, as you can see, we have our tactics and then the leaders who are responsible for deployment. And then yellow means that we're moving, but we're moving slowly, and green means that we're on target. So next slide, please. So we're probably going to just glide through the next few slides because I'm not going to read all of the tactics to you. But the key is improving our communication for nursing is rounding, quality rounding. And also treating our patients with courtesy and respect. Next slide. Here are the tactics to improve the survey administration processes. What we do is clean the data files before we upload to Press Ganey. Other ways for us to improve the survey response rate is by reducing the supplemental items. Some of the questions, currently we have about 34 questions that are customized through Press Ganey, but then CMS only requires about 29. And so if we reduce the 34 maybe down to 5, the questions will be minimal, and we're hoping that that will help improve the response rate. We are currently sending out Spanish surveys as well as English. During post-discharge phone calls is something that we're looking into doing. We've also discovered that when we mix the mailing survey along with the text and the electronic survey, and also having the post-discharge calls, that will improve the response rate as well. After digging some deeper into our surveys, most of our patients between age 40 to 69 are the highest response. And from reading a lot of different research paper, the age 45, if you call them and remind them to fill out the survey, the response rate will improve. So that's one of the tactics that we're working with, having the nurses calling the patients. And the next slide, please. CMS requires, again, that we collect the OAS CAPs starting in January. This is something that we actually implemented, and we are on task. Since it's so new, we don't have a baseline or a target to share just yet. Okay, next slide. Yes.
Yeah, I'm looking at the color coding, and it's mostly green, yellow, and at times gray. How do you get from green to gray?
So the gray means that these are the ones that we're continuing to monitor.
Okay.
Yeah, those are the ones.
So you're at target and you're monitoring.
Oh, I'm sorry. Okay. No, gray, for this one, Jen, gray means we're done, right? Yes, gray means we're done.
Okay.
Yeah.
And you said yellow indicates that you're making progress slowly?
Yes.
And how will we know, because they'll go to gray, or?
How will we know we're moving?
We've made progress, right?
If we're on target, we're green, and yellow means we're moving, but we're not doing it as fast as we would like.
Okay.
Yeah?
Okay. Thank you.
Thank you. Next slide. Okay, so please note that this is by received date, rolling 12 months. This is how CMS would like the report and also Leapfrog also looks at it by rolling 12 months by received date. As you can see that we have our valleys and hills, but we are working on certain tactics to help improve that. And the other thing too is there's a disparity in the gap when you do the receive date, is that the surveys could come in 4 to 6 months from the service date. So next line, please. Next slide. So I'd like to always look at it in a different way, is by looking at the discharge date, so that we could see whether the initiatives are being, if there's any change or any progress. And as you can see, when you look at it by the discharge date, it is going upwards, right? We are improving. Next slide. So here we have the receive date. We are training the nurses on providing quality rounds to improve the scores. And also we're providing refreshers on our CI Care training. Again, CI Care is like AIDIT, except AIDIT is missing the connect part, which is our first C for CI Care. And okay, and so for the nurses domain, what they're looking at is that the nurses are treating you with courtesy and respect, they'll listen to you carefully, and also that they explain to the patients in a way that patient can understand. Next slide. So here we look at the discharge date. You can see that we are going upward. During October 2023 to December 23, there was an unrest due to our previous CEO stepping down. Usually when there's uncertainty, there's a lot of stress for staff members, and we know that if the staff is unhappy, then the patients are unhappy. So we're hoping that once we have our CEO, things would get better besides all the new initiatives that we are doing. Next slide. So this is just another way I wanted to show you, 69.3% of the patients are saying that we are always treating them with courtesy and respect, that we're always listening to them, and that we explain things to them carefully. But we have 20.2% are usually. So if we could work on making sure that our staff members are consistent, we could move that up to 89.5%. And so that's with the CI Care, more reiteration, reminding them, every interaction, every time we need to provide CI Care to our patients and our colleagues. Next slide. Here is our response rate results. The national average response rate for inpatients is actually 22.6. We are at, I can't see with my glasses. Well, we're below. we're at about 10. And again, if you need me to reiterate, we're going to work on reducing our supplemental questions, provide the post-discharge calls to remind that the surveys are coming from Press Ganey. A lot of times patients don't realize that Press Ganey is our third-party company, so they're waiting for a survey from Cook County. So reminding them that it's Press Ganey to help them take the survey, confirm the correct contact information, and also CMS is going to start allowing proxy completion. Prior to this being official, family members who fill out the survey get tossed aside. So now when the family members fill out the survey, we can add that into our scores. So on a positive note, which we don't have, is that our ED response rate is at 11.8%, while national average response rate is 8.4%. And that's the end of my report. Do we have any other questions?
Well, do we know what was happening in August that was helpful to,
Do we have a what?
do we know what was happening in August of 2023 that was helpful?
Which slide are you looking at, Dr.?
The last, Stroger OPEX, patient experience performance monitoring. Last slide before the work group report.
In August.
Slide 11.
I don't know, but I could dig a little bit
Okay.
deeper, if that's okay with you, Dr.
Yeah.
Bye, yeah.
All right. Any questions? Go to Providence.
Okay, Michael.
I do have a question, because I thought for the press Ganey surveys that go out, how are those sent to the member? What vehicle, what?
So, yeah, so right now, they're being mailed out to the patients, yes. And then some of them also, they have text, they also get the survey via text and also email.
Okay, so
Yeah.
we're using all three.
All three.
Ways to get it.
Correct, yeah.
Now, how long after the services are rendered or the experience itself do those surveys follow?
It random, for us to mail out the survey right away, right now, we're looking at 3 to 7 days, right? Yeah, about 3 to 7 days from discharge.
And the patients, I assume, or their surrogates are informed ahead of time that they could expect their survey to?
Yes, so we have a quiet pack that we give to new patients when they come in, and patient relations would actually talk to them, greet them, and then also remind them about that. Discharge folder that I hand out, I think last month, it also has a reminder to do that, and then social workers also remind them as well. Yeah. Any other questions? No, thank you.
Good morning. Next slide, please. And thank you. I'm Mike Moonin, Chief Nursing Officer for Providence Hospital, and with me.
Good morning. Rafael Parada, I'm the Director of Nursing Operations for Providence.
Good morning.
So these are our tactics similar to what Lynn had for Stroger. For the first two tactics, we have our leaders, our new leaders rounding on the patients when they're being admitted and when they're being discharged to see how their care is going. We did start IROMs last week, which is we put the information into like a website, our Press Ganey website. Excuse me. So we did start that, and our leaders are reminding, and we'll go over that number, but our leaders are reminding the patients to take the survey at that point as well. And then we are still using the CI care framework for our nurses and healthcare team. And I believe we had a class a couple months ago, and that class was also taught during orientation here as well.
All right, next slide. So I think we're trying to be thoughtful and methodical in implementing a lot of the same strategies that we're at Stroger, bringing them over to Providence, as we're also filling out our leadership team. So one thing I will highlight is that we had a lot of vacancies. So in the last few months, we filled the ED manager, the inpatient manager, and a director position. So doing great work already with those teams in improving our patient satisfaction. The first initial phase, as Rob said, was to roll out the CI care model, which is the core model of improving patient satisfaction. And now we're moving into hardwiring the rounding. So this is our rolling 12-month communication with nurses. And you can see, a few hiccups along the way, but over the course of the 12 months is trending upward. Next slide. And then this is similar nursing domain communication with nurses, quarterly look, and again, shows with a few hiccups along the way, but for the most part, over the last year, we have been trending upward. And I think a lot of what we're doing is, one, having a leadership team for nursing there has been extremely helpful. The staff is there a lot of them have been there a long time, very dedicated. So giving them, a lot of feedback and rounding and FaceTime and a lot of gratitude for the work that they're doing. One of the things that we implemented is our leadership team has to send 2 thank you notes a week, to somebody who is on the teams. And we're pretty, religious about that. Next slide. Okay, so our one challenge is, improving our response rate, and as, Stroger is struggling, so are we. We have implemented the managerial rounding, and are monitoring that in a different slide that is not included. I can look and see how well, my managers are actually getting to every patient. And I believe our number was roughly 80% of the time they were, getting to a patient, which is, can be a challenge at times if a patient comes in and out before that manager can see them. So really socializing the survey during that rounding experience, getting a lot of feedback on how the care has been. But in terms of our response rate, we still are struggling. And one of the tactics that we're looking at now is what is the tools or rubric for the survey from Press Ganey, and seeing if there's any opportunities there. So, at a high level, if a patient was in, a few days apart from a prior visit, is that survey somehow getting lopped off? Don't have a lot from that yet, but that is the work we're doing right now in terms of improving the response rate. And I think that is it for our patient experience. Any questions?
Well, it just looks like, the December, January, continue to work on those numbers, but
Yeah.
we'll see what works at Stroger that might be applicable.
Yeah. Thank you.
Thank you. Other questions? Ambulatory?
Good morning. My name is James Bristol. I'm the Director of Patient Experience and Employee Engagement. Similar to Provident and Stroger, we are following the same format of the A3 and focusing on communication with staff. We are working with recognition and ongoing coaching and ensuring that all new employees go through CI care training when they're onboarded. We're also making sure that all the different areas are using their scorecards, which help keep the staff engaged and motivated in their performance. Next slide, please. So here we have the courtesy of registration staff. This is a new question that has been added. It was added because it is directly related to the likelihood of recommending. We do not have a lot of historical data for this question as of yet, but you can see that we do have a little bit of work to do looking at February census. Next slide, please. And for the concerned nurse assistant for problem, you can see we're falling a little bit below right there. However, the overall 12-month trend, we are slightly leveling off. Next slide. And then for the provider explanations, problem conditions, again, we're a little bit below, but the overall trend for the rolling 12 months is that we're leveling off. Any questions?
Any questions? All right. Thank you.
Thank you.
We have throughput, Providence, Dr. Elliott. Ready, Amy O'Malley.
Hi, good morning, everybody.
Good morning.
Next to me is Amy O'Malley. She's one of my partners in the emergency department to take care of people. She's the director of nursing. And, Raji Thomas briefly explained what we were doing from the in emergency medicine to conquer our LWAD or LWBS, left without treatment or left without being seen. But before I explain that a little further, I just kind of want to let you all know how we got here. Back about 19 months ago, Provident opened up to ambulance runs, as you all know. That increased our volume 275 to 300 per month. But besides the ambulance volume, was also an increased walk-in volume. I think everybody listening to the news realized Provident was open again, so they started coming, which was a great thing. And besides that, our clinics also have increased volume. There's more specialties there and more, so there's just more people there. So when they have urgent health care needs, they come to Provident. So volume went up drastically, 25 to 30%. And we're still about 25% up in the ED. So we have a somewhat of a capacity in the ED. We have only so many beds. So the volume was going up, we were reaching capacity. We had a nursing shortage back in the fall, so our LWATs really went up. The nursing staffing problem has greatly improved, but we still needed to conquer, our LWAT problem, which was up in the 12 or 13%, which is just way too much. So Andrea and Jennifer helped us set up a program here, how to conquer that, and there's two parts of it. One is to implement a provider out in triage to see the people as they come in right after registration, talk to them, make sure they're okay, bring them right back if they have to come, but also assure them that they're going to be seen, and they have been seen, just maybe not vitals yet. And the other aspect is implement pull to full, and pull to full is bringing the patients back as they present to triage them at bedside rather than have them triage out in the triage area and go back into the waiting room. Keep the beds full, as full as possible. So we implemented that on Valentine's Day, February 14th. Next slide, please. So there's several aspects to that. We added it on the tracking board and extra computers out there for our users to use, our providers to triage. We also wanted to make sure we were capturing the patients correctly, and so we made sure our ward clerks who finished out the charge realized that we did a quick, rapid evaluation on the patients. So we did. We're getting daily LWAT reports and weekly LWAT reports. I don't think we're quite at the monthly LWAT reports yet that I have seen, but so it's good to know what we're doing every day and looking at our numbers. Amy and I did partner with nursing and the providers to do the pull to full as well as the rapid evaluation. We're in the green at that. That's working. Whenever we have an extra tech or enough techs in emergency department, we have them out in the triage area to help assist the nurses with vitals and doing EKGs and bringing the patients to X-ray or bringing them back. Next slide, please.
Dr. Gallagher, are you seeing in this more mental health volume at all in the emergency room?
We have seen a lot more. I can't give the exact percentage, but a lot more since the ambulances started because they bring them to us. Most mental health patients, when they're having a crisis, they usually call 911. So we were getting some, but most of them were not walking to Providence or being brought by their family. Most of the time, 911 is called. So they take them to the nearest hospital. But since we opened the ambulance runs, yes, we've gotten a lot more because of that. So our goal, like I said, our LWAT were about 12%, and our goal was to make this work with just 4.5% and a stretch goal of 4%. So as you can see on the slides back in February when we first started, we went down from around 12%, if I can see it.
To like 5.55%.
Yeah.
Yeah, so that, we're starting to see our trend go down for the rolling 12 months left without being seen, right?
So this is rolling, yes. So we're at 6.9% in March. And next slide, please.
And we actually do have, our data from April showed that we were below our stretch of 3.77%. So we're going to see that continue to go down that 12-month rolling.
Yeah, I think there's one more slide, but I think Debbie stepped out. So yeah, this is, our last slide. So there's a big difference here, tactical difference since February 14th of almost 66%. So we're making some great progress, and as Amy just said, it's 3.77% in April. I think we have, we've gotten much better. I think we could do better. I wish every provider, nursing and doctors were role providers, but, just not everybody's human. Some do a lot better than others, and we're going to try to see if we can, highlight that a little bit to let those who are doing great know that, and let those who are not doing so great know that. But all in all, I think we'll be fine. We got a great team, and we made some great progress.
I appreciate it. Any questions? Thanks for the good work. All right, we'll go to regulatory and accreditation updates by Irene Marks.
Good morning, everyone.
Good morning.
So the regulatory update for May, is that Provident went through its IEMA recertification, which is with the Illinois Emergency Management Agency to check, whether or not we're in compliance with all regulations pertaining to safety. And they, did a wonderful job. There were no findings.
Great.
Also, Stroger Laboratory is preparing for the CAP survey with the College of American Pathologists. All efforts are on track. This is expected to take place during the summer between August and maybe November. So we still have a little bit of time, but as I said, all their efforts are on track. Stroger Hospital and ambulatory clinics are continuing to work on their preparedness efforts. And there are weekly report outs based on our findings from our mock survey in January. And so right now we are about 86%, between 86 and 90% compliant with resolving all those issues. But we also are looking at some other efforts to make sure that we're well prepared by the time the surveyors are on site, which is expected in October of this year. So a couple things we're looking at is we want to just optimize our command center for survey readiness. So we're looking at a couple of things to try to decompress the area so that we have the right people there that are that can really help us move the survey forward in a more efficient way. And also, as I said last month, just trying to pair up the survey groups to make sure we have the right folks paired with our surveyors so that we can make sure that we can address any potential issues, in a timely manner. We also have launched the Joint Commission Tracer tool. It's an electronic tool, and it will be in addition to the Syntax tool that our EOC team currently uses. And we have been beta testing it, the ambulatory team, out in some of our ambulatory sites, and it's going very, very well. And next, we will be training our leaders to also start to participate on their local units to also use these tools. And these tools are tailored to the specific areas in our organization, such as dialysis, inpatient units, ambulatory units, and just all throughout the organization. So it's really, really going to be helpful and more robust and give the leaders and the staff an opportunity to understand what kinds of things are being looked at and what kinds of things are being assessed. And they're all written in a positive manner so that you know that if you're not doing these things, you should be doing them. So it's more of a teaching tool as well. So it has a dual function. The other thing is we have purchased this 13-week webinar with Joint Commission. It's called the Breakfast Briefing, and it will go through every single one of the Joint Commission chapters. And it gives the opportunity for staff when they attend these webinars to ask the consultants questions. They are also taped, so even if you couldn't go during that particular session, the live session, you can go back and review it later. And there are CEUs that will be awarded for people that are able to attend those. So we're looking forward to that. In addition, we are looking to relaunch our regulatory readiness meetings with all our departments coming forth to report how they're doing in preparedness efforts, because the mock survey report outs are just looking at findings that were identified. This session these meetings are supposed to be geared at what activities are you doing to prepare your staff and your environment to make sure we're survey ready. And we are also participating on different group department meetings to also give tips to different staff and leaders and providers so that they can also address some of the identified items to make sure that they have sustainable solutions. And that is the end of my update. I'm happy to take any questions.
Any questions? No.
Thank you.
Thank you.
Thank you. All right. Can we now go into closed session? Actions I anticipate to be taken in open session after the closed meeting is adjourned. I need a motion to go into, I'd like to entertain a motion to go into closed meeting pursuant to the following exceptions to the Open Meetings Act, 5 ILCS 120/2, C 1, 11, 12, and 17.
So moved.
Second.
Motion has been made and seconded. Is there any discussion on the motion? None. Hearing none, then Madam Secretary, please take the roll call vote on the motion.
Roll call vote on the motion to go into closed session, aye or nay? Director Curry?
Aye.
Director Harrington?
Aye.
And Chair Bob?
Aye. So the ayes have it, motion carries. We'll go on a closed meeting, so if the members of the public and those staff who are not required to attend can leave exit room, we can start.